Right. Well, welcome all. I know that we're having people, log in here just another moment or so, but just want to say hello. I'm Eric Rice. I'm the one of the co-directors of the Center for AI and Society here at USC, and welcome to our spring seminar series. And I am going to turn things over to one of our doctoral students, Graham, to actually do the introductions for today.
Hi, everyone. I'm Graham DiGiuseppe. I'm a PhD at the USC School of Social Work, and I'm a student leader here at CAIS. So we want to thank Dr. Mair for this coming and giving this talk. So Dr. Mair is an associate professor and vice chair for research in the Department of Behavioral and Community Health Sciences at the University of Pittsburgh School of Public Health, with secondary appointments in the Clinical and Translational Sciences Institute and Department of Epidemiology. She also serves as director of the Center for Social Dynamics and Community Health and associate director of the Public Health Dynamics Lab. Her research seeks to understand structural and contextual influences on substance use related problems with the goal to reduce these problems in community settings. So we thank Dr. Mair, and I'm going to go ahead and let her take it away and begin her presentation. Thank you.
Thank you for that introduction. Hold on, it's moving forward for me. There we go. I'm very excited to be here today. Oftentimes when I talk about agent-based models and some of the things I'll be discussing today, the audience tends to be sort of on the public health substantive side or the method side. And I'm really excited to be presenting here at a center. It sounds like has folks sort of who bridge that divide, which can be difficult to find sometimes. So what I'll be talking about today is collaborative system science. And so the talk's called, Can Collaborative System Science Methods Improve Intervention Strategies to Reduce Alcohol-Related Problems? Hopefully this won't take more than 40 minutes or so. So I guess probably the best way, this is how you typically do it. If you have questions, you can feel free to drop them in the chat during the presentation, or, there's something urgent to ask, feel free. I'll try to pay attention, but otherwise, hopefully leave some time at the end to hear from all of you. So with that, I just want to start by saying that I have no conflicts of interest. And I would also like to thank my funders, NIAAA, for the 2 grants that funded the work I'll be presenting today. Just a little bit of background. I know that some of you in the audience are probably very familiar with this, and some of you maybe less so. So I just wanted to give sort of a couple slides of background information, sort of how I think about alcohol and alcohol-related harms and problems, really from a public health perspective. So we often talk about alcohol as one of the leading actual causes or modifiable causes of death in the United States and worldwide. It's estimated about 140,000 deaths per year in the US, if you sort of look broadly at all of the alcohol, fully and partially alcohol attributable deaths. So they are sort of multiple categories here. We can think about, quote unquote, acute alcohol related problems. So these are things like partner violence, injury, alcohol poisoning, and some sexual behaviors like condomless sex or sex with multiple partners. There are also, of course, a number of chronic alcohol-related problems that are really important. One thing that just recently has been gaining more attention is how many cases of cancer are really linked to alcohol consumption. It's estimated about 75,000 cases in the US per year are attributable to alcohol use, as well as, of course, alcohol use disorders, liver diseases, psychiatric disorders, cardiovascular disease. Another really important thing to point out, I think, and oftentimes when I think about alcohol and sort of population level harms related to alcohol consumption, is this idea of alcohol inequities. And this is not my figure, this is someone else's, the link is there down there at the bottom. But the idea here is really that when I say alcohol inequities, I'm really talking about that middle arrow sort of between alcohol consumption and health outcomes, so that the amount and sort of the patterns of alcohol consumption and the harms that accrue related to that alcohol consumption can vary by, particularly in this country, minoritized racial identities, as well as minoritized sexual gender identities. sort of differential vulnerabilities, and there are really structural and other interpersonal contextual factors that lead to those inequities. So you'll see when I get to my models and sort of how I think about some of this, to me, this is a really important question to understand around alcohol use. And the reason that I'm sort of going to be presenting some of these agent-based models and other solutions today is to really think about what are the public health solutions to this public health problem. And in some ways, when it comes to alcohol use, we've known solutions for a very long time. That's because, for example, in the United States, alcohol is oftentimes it's controlled at the state level. And so, for example, when a state goes from public control to a privatized version where so sort of it's either only sold by the state or state-controlled liquor agencies, to like your grocery stores and your private liquor stores can sell alcohol, use and related harms go up a lot. And there's been wonderful evidence around that for 50 years, really. So I like to think about environmental prevention, right? Which is how can we change the structures and contexts of our lives to prevent these harms. Some of the other alcohol control policies that there's pretty good evidence for are things like increasing taxes, regulating the density of alcohol outlets, limits on days or hours of sale, and as I already mentioned, no privatization of sales. And then a little bit more specific. So those are sort of broad things that we can do, and specific to the two things I'll be talking about today. One is sort of what are alcohol control policies focused on underage drinking. And here I'm thinking about underage drinking at parties. So like a high school student throwing a party. So what I'll be talking about today is something called social host laws, and these can be criminal or civil. They actually are typically implemented at the local level. So it's not a federal policy, it's not a state level policy. These are really like local jurisdictions both implement these laws differently and they enforce them differently. And so a social host law means that if I have a party, roughly, there are hundreds of variations on this, but the general idea is that if I have a party at my house and there are underage people drinking there, I am legally responsible for that. It's sort of, you're not getting the people who are underage and drinking sort of in legal trouble, but it's actually the host of that party who is responsible for that underage drinking at the party. And these can be enforced by things like what are called party patrols or field patrols. Oftentimes this is done in partnership with law enforcement, which is a side note to sort of, the way we think about law enforcement these days and public health policies, that's not as straightforward. There are pros and cons there. We'll just put it that way. That's not the point of the talk today, but I think there's a lot to unpack there as well. But this is the general idea. So you would think because there are thousands of these implemented, on the books and implemented across the United States, that there's really robust evidence that a social host ordinance works. However, the actual evidence that we have is somewhat limited. And some of this is because of variation in implementation, variation in enforcement. And the idea really here is, given that we have such limited public health resources, what is the best way to implement these kinds of policies? The second problem I'll be talking about today is alcohol-involved sexual violence. And so when it comes to alcohol control policies here, if we think about alcohol-involved sexual violence, this is sort of the standard social ecological model, which, as someone who likes to use systems dynamic models and think explicitly about mechanisms, I don't love sort of a by-the-book social ecological model that doesn't show the relationships between these levels. But I think it's still nice to show an image like this to sort of get a sense of course, there are individual level factors that are related to alcohol-involved sexual violence, and interpersonal, of course. And if we're thinking about college campuses, which is the focus of the work I'll be showing today, there are things like how many bars are on your campus, how much access do students have to locations with heavy drinking, is there a Greek system, and how good is the access to clinical and counseling services. And then, of course, there are social, societal, structural factors as well upstream. If we think about what are some of the campus level policies that we can implement to reduce alcohol-involved sexual violence, we could think about, for example, better provider communication within a campus health clinic. There are a number of harm reduction strategies that we could implement that are potentially really useful. Apps, as well as the project that I'm working on, I'll talk to you about in a moment, is actually in relation to an ongoing RCT on 30 college campuses in Pennsylvania that's now extended to the United States. So they have what they call a learning collaborative approach. And I'll talk more about this learning collaborative, but it's really bringing collaborator experts from across the campus who have different, but all really valuable insights and perspectives on why why alcohol-involved sexual violence is such a persistent problem. And then, of course, the alcohol environment linking back to sort of similar to underage policies, just access and ease and cost of alcohol. This is almost the same slide as I said for the parties, this idea that we have limited evidence of effectiveness. There's variation in how these things are implemented. There's variation by campus, other campus environments. You can imagine a huge state school with 30,000 students would look very different than a small liberal arts school with 1,000 students in terms of the mechanisms and the, quote unquote, riskier environments and what we could do, what would be the most effective ways to reduce alcohol-involved sexual violence, enforcement levels, and once again, we have limited resources, so what's the best way to implement? So you can hear, this kinds of questions that I'm asking. And so what I want to sort of talk to you about today, and maybe this is one of these instances, these rare instances where I'm preaching to the choir about these kinds of things, but I would like to make the argument that systems science approaches and systems thinking can really help here. So this is the sort of classic systems thinking iceberg. Probably many of you have seen some version or other of this over the years. This is the idea that sort of the events that we observe, right, over this quote unquote line of visibility, it's not just sort of what we see. If you sort of dig down beneath, so why do we see what we see? The first thing, sort of the first level underneath that, we can think about, like, what are the patterns, what are the trends, the descriptive epidemiology, sort of understanding and mapping what's actually going on. And then the next sort of bit underneath there is really bringing in campus level things, structural ideas. So what are the structures and systems that are in place in our culture, in our country, in our state, on our campus that lead to those patterns and trends that we see? And then below that is really where the modeling comes in, right? Which are the details I'm going to be going into here. So whether or not we explicitly think about it, we all have mental models of how the world works, right? And sometimes our mental models are the same, sometimes they're different, and sort of how we view how we think about the feedback loops and the interactions between structures and systems and patterns and trends and the events that we actually occur. I think, the reason I'm so interested in all of this is if we can better understand those mental models and those causal associations, we can better design and implement and choose interventions to reduce at a population level the problems that we see. In the last, I probably first heard about agent-based models when I was a PhD student at the University of Michigan, and I thought, oh, these are kind of cool, but I'm never going to actually use them. And sort of gradually over the past decade of my career, I brought them in and implemented them more and more in my own research. And the reason sort of why I've warmed up to them and really sort of seen them as a wonderful and complementary approach to some of the other work that I do, that's more like secondary data analysis and sort of more standard public health approaches. I love that these models can really help us illuminate underlying social mechanisms and develop and test theories about why we see what we see, right? Those mental models at the bottom of that systems thinking iceberg. Another reason is because you heard me mention environmental prevention earlier. Most of the work that I'm interested in, or the interventions I'm interested in, are how can we change our environments to impact health behaviors rather than sort of trying to intervene at the individual behavioral level. How can we change the structures of people's lives? And so an agent-based model gives us an opportunity to really emphasize the interactions between people and their environments. An agent-based model can be created just to sort of show interactions between people, but there's really no reason to use an agent-based model unless you have an explicitly spatial and environmental question, sort of that, for example, interactions between people look different in context A versus context B, or you sort of say person A and person B only interact when they're together at a bar at this hour at the same time. So it brings in place and time and those kinds of interactions in that way. And that's why they are really useful for the kinds of questions that I'm interested in. They also allow you to model changes in your environment and subsequent changes in behaviors, and think about these environmental or community preventive interventions. And what would an intervention look like if we're trying to change an individual agent or person's behavior in a vacuum? What if we change the environment in which they live? Or what if we think about an intervention that would change sort of how people interact with their environments or with one another in specific contexts? Agent-based models let us think of a number of detailed features. So these individual interactions, responses to other people, variability. So you could have a distribution sort of in, so it doesn't have to be deterministic, like if A happens, then B always happens. It might be, here's the distribution of the number of drinks that an adolescent might have at a party with a mean and a standard deviation, or it could be a threshold effect. I mean, you can really, the best and the worst thing about these models is that they sort of give you unlimited options as to how and what you want to model. And you can also think about individual responses to a policy or an intervention. They require us to translate our social theories, be explicit about our assumptions. What I oftentimes hear when people are sort of distrustful of an agent-based model or a little less sure about it is, well, but you're kind of making it up, or how do you know this? Or, because you have to sort of lay out every single one of your assumptions very explicitly. I actually think that's a good thing. There are so many assumptions that we make when we even just like run a linear regression model, right? And it's just very easy to not be explicit about it, or not always think about all the assumptions that we're making when we do those things. And they require us to examine our internal consistency in a number of ways. Agent-based models can be thought of sort of as an experiment to think about different runs of your model. It's really sort of like a little experiment to think about counterfactuals. So you can change just one thing, and then how does that change the outputs and everything else in your model? So you can test different ways of thinking about manipulating exposure to impact health. And you can examine the effect of manipulations on different targets. So you could think about changing, shifting the entire curve, or narrowing the curve, right? Reducing inequities. Kind of talking in public health lingo right now, but that's the goal. So before I get to the collaborator models, which is what I'm really excited to talk to you about, I wanted to briefly talk a little bit about our prior project that we're still working on as well, which we call the Framework for Behavioral Risk Models of Alcohol Problems. This was something I did in partnership with my colleagues at the Prevention Research Center in Berkeley, California. This is the research center where I did my postdoc and was for a couple of years before I came to Pitt. The idea here, this was part of a larger P60 grant. And so for those of you who are not familiar with those mechanisms through NIH, what that means, it's sort of like 5 or 6 distinct research projects, or 3, 4, 5, 6, that are sort of wrapped around a common theme. And PRC has had a center grant for 40 years, all about environmental approaches to prevention specific to alcohol. And so the nice thing here is I was able to bring in this agent-based model I'll talk to you about in a moment called FRED, which is the platform, to really think about behavioral risk models instead of a standard infectious disease model. And can we think about a broad range of alcohol-related problems in California communities, because it was linked to 5 different ongoing projects that all focused on slightly different questions around that topic. And then once you build the models, then you can test, then you get into your sort of experimental world where you can think about different implementations of interventions. I'm just going to show you one model so you get a sense, and not even go into the details, so just like really big picture, like maybe step 2 in terms of all the details. We built a model. The goal was to understand the ways in which parties impact adolescents' alcohol use. So here we're thinking about how much they drink at a party, what proportion of adolescents drink at the party. And so it's really looking at drinking behaviors in adolescents' homes. It defines an initial population of interest. And here we're looking at 15 to 18-year-olds in Contra Costa County, California. So that's in the East Bay in California, near where PRC is located, sort of, it includes Berkeley and Oakland. Or not Berkeley and Oakland, it's immediately adjacent to Berkeley and Oakland. And then what we're doing is we're modeling attendance at parties, at the homes, of people who host parties. And we think about what are the effects of the effect of drinking behaviors at parties on current and future drinking behaviors of those who attend these parties. What we use something called FRED. This is the Framework for Reconstructing Epidemiologic Dynamics. Anyone who is from or has visited Pittsburgh probably knows that the patron saint of Pittsburgh is Fred Rogers, Mr. Rogers. There are murals of him everywhere. His show was filmed here right down the road from where I work. And his motto was, "Won't you be my neighbor?" And so this is a model of, neighborhood environments, really. And so they named it FRED to begin with. So it's a very Pittsburgh acronym. So this is not a model, but it's an open source agent-based modeling platform. So if any of you are interested in this after my talk today, if I haven't scared you off, you can see this link down here at the bottom, fred.publichealth.pitt.edu. You can go there and explore it a little bit. We're always interested in working with others who would like to use this platform. So this platform just sort of is a very realistic agent-based model. They can go anywhere from like sort of a very conceptual toy model to this is meant to represent the entire United States. You break it down sort of in chunks of counties throughout the US down to the census block level. And it has social network capabilities built into it, which were really important for this agent-based model because invitations for adolescents to go to a party and drink at the party sort of flow through their networks as well as their homes, their school locations and their home locations. So Fred has the census-matched synthetic population. It used data from the census, land use, school data, business data. They had this has unfortunately, this is still based on the 2010 census because, as many of you are probably familiar, 2020 census has been a rather slow rollout to all the detail down to the block group level. So we're hoping in the next year that our pseudo population will be based on the 2020 census, but for now it's based on 2010. There are 306,970,295 agents in this model or people, and they live in 117 million households that represent down to the block group or block level, the real populations. So it's a synthetic pseudo population, but it's representative at sort of a spatial level. And each agent already has a home, has a family, has a school, has a workplace, has commuting patterns. So there are a lot of sort of additional things you can add in, but at the same time, it has some like basic stuff that you do not have to sort of reinvent the wheel. Each agent has a demographic profile as well, right? There's a race. To me, the biggest weakness in Fred is they don't have ethnicity in there yet, but it will be there for the 2020 census, gender, et cetera, right? All the demographics that you like from the census you'd be interested in. This is for those of you who are not the social work public health folks and you're interested in sort of the architecture of Fred. This gives you a little bit of information. We have the synthetic population that I talked about, and you sort of model it by having health conditions, behavior models. You can bring in these policies. They go into the Fred engine. There's Fred Web with the outputs that you can map the outputs as well as sort of the conditions, the outputs that come there. This is just to give you a general, this is a slide that I usually don't use when I present this, so it's a little bit in the weeds, but I thought some of you might be interested in this or could refer back to this later. Within Fred, the person building the model, the modeler, is going to select the county or state that they're interested in, select a time period. You can run it. The model I'm showing you now, we run over a 1-year time period, but it can be up to 100 years. You define the conditions that you want to track and see how they change. You can add in additional places or networks. So some of our models, we added in the actual locations of bars in Pittsburgh, for example. You can add in places to the model. You can add in sort of routine activities, commuting patterns, et cetera. And then Fred will set up your population, set up the initial conditions, update your agents. The time steps are 1 hour as they move forward in time. Keep track of what you're interested in, and then report your data, plots, maps, and movies. And then we also have this great library of conditions. So for example, like now that we have a lot of conditions that have to do with drinking and alcohol use, and they are available right in this library. If someone else wanted to use a similar condition for their model, it's there and it's available. Here is no numbers here, but to give you just like a general sense of what this party model looks like, you can see we have characteristics of the hosts of the parties, characteristics of the parties themselves, as well as characteristics of the people attending the parties. And there are social networks that we use to add health data, which add health data are old. The add health population is my age, to give you a sense, but they have a really nice distribution of the number of friends and number of friends within and outside of your school. So our distribution of friendships matches the add health data just because sort of like the biggest adolescent social network data set that exists. So you can see like you're more likely to host a party if you're older and you already are a person who drinks and you have more friends. And then, the relationships between how likely are you to actually attend and be invited to a party, and if once you're invited to attend the party and then drink at the party, and there's some thresholds built in, and a lot of them have to do with sort of larger party size, which data, we have a lot of descriptive data that show that, more alcohol consumed per person at a larger party, for example, and a greater proportion of people who are drinking at the party is more likely to get others to initiate or drink. So, I could give you an hour left. I could talk for an hour about this, but I just, so I apologize for throwing it up there and then sort of like quickly moving on, but this just gives you sort of a sense of the architecture of this model. So each simulation, right, we'll start with different hosts. We run these oftentimes 10, 20 times. We typically don't need to run Fred models thousands of times. They tend to be pretty consistent in their output. But these are just as an example. This is Contra Costa County, as I said, right next to Alameda County. And we have the larger circles are locations of the hosts of the parties, and the smaller circles are the home locations of those who go to the parties. And every week the parties look a little bit different. And these are just two different initial conditions. So we built the model, and then what we really wanted to do once we built that model was think about what would differential implementation of a social host ordinance or differential enforcement of a social host ordinance look like, and how would that change some of the main outputs of our model. So the way we decided to model that within this model really is to say, okay, if there is a party patrol out shutting down parties, what that means is that a certain percentage of our parties will be shut down 3 hours early. So something I didn't tell you before about the main model is that the parties run between 1 and 6 hours. And so, for a party to exist, there has to be a party for at least 1 hour, but they sort of shut down 3 hours early. And we say anywhere from 10 to 20, that happens from anywhere from 10 to 20% of the parties. And then we looked at sort of these different changes. So, simplifying the main model, like what does that look like? What we would do here is we change the party length for a certain percentage of the parties, which of course impacts, because we had our people at the party, if they were drinking, it was sort of a rate of drinking, like drinks per hour. So you're there for fewer hours, the number of drinks you consume is going to change. People arrive, not everyone arrives at the party at the beginning of the party. So if it shuts down early, what ends up happening is that the eventual party size is smaller because not everyone gets there before the party ends. And so we have some of these thresholds about the number of people who drink at the party, as well as the party size, then impacts sort of people who already were, those who drink will drink, change how much they drink, as well as sort of, is there any drinking initiation at that given party? These are not final results, but just to show you, for an example, this is between 0 to 20% of the parties getting shut down early along the x-axis. And the y-axis is sort of the percent change in some of these output characteristics based compared to the base model, right? When we don't shut any parties down 3 hours early. So some of them are just checks, right? Like the number of parties should stay the same. And that's because we didn't have any of them not start. We just had them shut down early. The proportion of parties that have any alcohol available is roughly the same, which is also what we'd expect to see. And then of course, party length, we're saying it's going to be shorter. So we expect that to go down. So that's kind of a check. And then we see sort of the number of people who have ever consumed any alcohol and who consumed alcohol at the party and the total number of drinks consumed, right? They're obviously all going to reduce, but you can see it sort of at different rates. So this is not meant to be like a final example, and I don't want to sort of overly interpret the results here. It's really just to show you what we can do with these agent-based models, and to, in the last 10 minutes of this talk, make the argument for why I want to take a collaborative approach to this sort of moving forward to the development of these models. Sorry, I had to move the window so I could see that slide. Now, okay, here we go. So that was just like general implementation. One of the other things we've done with the basic party model is to think about, for example, what if these party patrols are only in 10% of all neighborhoods, right? And what if that's random versus like purposely chosen? What if like a neighborhood or a person who's had a big party before is more likely to have their party shut down because the neighbors are more likely to call and complain? What if there's this idea of a permanent shutdown of a host that they can no longer, their parents say, okay, like absolutely not, we're keeping like closer tabs on you. So there are different ways to think about like this differential implementation. And then this model can also be used not just for social host ordinances, right? We could think about simulating like a just-in-time adaptive intervention, about messaging to sort of impact individual behavioral choices. Same as like information dissemination. We could think about changing alcohol availability. So a smaller percentage of the parties have any alcohol access, or there's a limit, like a maximum amount of alcohol at a party, and it runs out soon because it's more expensive or harder to get for an adolescent to get their hands on. Or maybe we bring in like, kids have parents, and so maybe parents are less likely to allow their kid to go to a party where there's alcohol because there's improved parent kid communication, or a social network intervention, right? So there are lots of different points there. And so really, this is just to say that I wanted to just quickly illustrate what I see as the usefulness of an agent-based model as developed by researchers and sort of content experts in thinking about mechanisms and comparing intervention strategies. However, and this is what I am excited to talk to all of you about today, is I think there's some really common limitations of many of the agent-based models that we build. On the one hand, it's great to go to the literature and talk to, research, quote unquote, experts who know a lot about the content and can help build these models. At the same time, we have limited perspectives, right? And like the collaborators and the people whom we are actually trying to represent in our models, their mental models might be really different. So if we think about modeling as an exercise of sort of sharing and coming up with a shared explicit model of reality, we all come with different internal implicit mental models, and as we build and share together, you can imagine sort of where we end up in the final model would look very different in a room full of researchers versus a room full of adolescents versus a room full of adolescents and researchers together, right? So this new project that just started about 6 months ago, it's a brand new project, also funded by NIAAA, that we have named CAMPUS, Collaborative Model Building Project to Understand Sexual Violence. The overall aims of the entire grant. So today I'm focusing just on the first aim, but I do want to mention the other two aims here because I think in particular, your group and you may all have some really great expertise once I get to the third aim. So the first bit is to characterize systems of alcohol use and sexual violence, as well as intervention opportunities on college campuses using this collaborative model building process that I'm about to talk about. And then once we have this collaboratively built model, we're going to implement it in FRED. So you saw the platform and how it works, and we can use the literature to parameterize variables. So that will be the second aim. And then the third bit is really to think about, once we have these agent-based models, is there a decision support tool that we could create that would optimize sort of campus decision makers in terms of like what set of interventions on our particular campus should we choose to optimally reduce alcohol involved sexual violence. So we have some sort of like human-centered design approaches, hopefully that we'll be able to take to figure out like to develop and assess preliminary feasibility of this sort of decision support tool. So collaborative model building, some of you may have heard of group model building before, which is sort of like informally trademarked idea. So this is sort of like a loose version of group model building. We take a slightly different approach, but none of this should be anyone who's familiar with this general concept of group model building. It's very similar. So the idea here is to co-create our models so that they have salience for our end users. We want to increase relevance and likelihood of producing research with impact. We want to include diverse collaborator voices. We also take a very iterative approach and capacity building orientation. So we sort of train or informally teach systems thinking as well as we go through this process with our collaborators. And so it's really all about co-learning. And as you see, I think that our agent-based models are very well suited to incorporating collaborator input or a causal loop diagram sort of as developed by a collaborative team. We piloted this summer with some folks in my Center for Social Dynamics and Community Health. It was a little bit different. It was online only via Zoom. We found it was not for the campus project, we'll be doing these in person. It was a little difficult to do online, but not terrible. And so we got a sample of just one group of sexual and gender minority college students. And we want to talk to them broadly about alcohol use and alcohol-related harms, just to test the feasibility of taking this approach. And actually, they ended up picking alcohol-involved sexual violence as what they were most interested in, which I promised there was no like we know that we didn't tell them to do that. They just sort of chose that. And I just want to show you, like, here's an example of walking through the steps. I'm going to show you the steps on the next slide. I'm just watching time. We're still can time. That like this was the first pass of the model. And then because it's so iterative, this comes out of the third session. You end up with a model like this, the causal loop diagram. And then you get even more feedback and they add in even more variables. So the different coloring here is to show that they were thinking about sort of important variables at the individual, interpersonal, community, organizational, as well as sort of structural, societal levels. But have these different color codes here and the feedback loops between them. And so there were some things that I was very unsurprised to see sort of come up here that one would expect. There were some things that none of us were expecting this group to bring up. So once again, I'm not going, like, because of time, I'm not going to the details of exactly what was shown in this model, just that this is what the process looked like piloting it. So now for campus, what we were doing, and actually we were having our first collab. So I don't have results to show you yet because our first collaborative model building is happening on March 24th. So in less than a month, we're really exciting. We're having our first group come together to begin this process. But the way we sort of have structured it is that we have a core modeling team. So that's myself and 5 of my colleagues who come from adolescent medicine, public health, a wide range of different backgrounds and perspectives, as well as 3 members of this learning collaborative. So these are people involved in a larger randomized controlled trial. We have someone who's a former Title IX officer at Pitt, someone who sort of works for the Pittsburgh Council on Higher Education, so understands sort of policies across campuses in Allegheny County, where Pittsburgh is located, as well as someone who works in the Health Counseling Center. And so this sort of the 9 of us together are the ones who design the studies, and there's a lot of work sort of in between sessions for collaborative model building that we will take on as a group. And then the collaborative model building groups themselves, some of them are only students, some of them are students and members of this broader learning collaborative, which is really anyone who has some sort of professional input or advice or expertise or opinion about alcohol-involved sexual violence from as broad a range of perspectives as possible across a wide range of campuses. And then some groups will have both students and learning collaborative members involved in them. This is what the 4 sessions look like. It's sort of 4 2-hour sessions together. The goal of session 1, what we do is we are basically eliciting variables. So we're saying, what are the causes of alcohol-involved sexual violence? And what sort of, what does alcohol-involved sexual violence cause? So, both before and after, from a causal perspective, alcohol-involved sexual violence. And so they brainstorm by themselves. They come together in small groups and sort of discuss their variables and put them on cards. Then they share with the larger group, and then people rank sort of in relative importance. You get, say, like 5 stickers, say, here are the 5 variables that I think are most important. And then we introduce this concept of connection circles, which I'll show in the next slide. Session 2 is really all about building connection circles from the variables that people have decided are sort of the most important. So our, between session 1 and 2, the core modeling team thinks about, okay, like which variables are unclear, or and sort of come back with those questions. So a bunch of connection circles are built, which are sort of standalone closed loops. And then we also sort of get some input about like which of these seem to be the most important. And then between sessions 2 and 3, the core modeling team takes those and builds out a preliminary causal loop diagram, like the one I showed you from the pilot study, right? So it's like one big system with potentially, not every single connection circle, but the ones that are potentially ranked as most important. Then you bring that causal loop diagram and you get feedback on it, right? And really a lot of this is sort of also reminding, teaching, maintaining that you can't put every single variable in these models, right? At some point you cannot translate them, and they're too realistic to actually be useful, right? So it's sort of this art form between like having it be simple enough to be useful, but not overly simple, so that it like no longer bears any resemblance to reality. And then what we'll also do is have a list that we have created basically of evidence-based interventions around alcohol on college campuses, sexual violence, and alcohol-involved sexual violence. And we will have, from their perspective, sort of rank what they think are the most important interventions, as well as brainstorming to think of potentially new and novel interventions, or like what's a variable you wish you could change, or you think would be useful to change, and how could we change it? So also sort of, thinking of new ideas. So evidence-based interventions as well as non-evidence-based potential interventions that don't yet exist. And then prioritize some of those. And then in the fourth, so then between sessions 3 and 4, the team refines that causal loop diagram based on feedback and begins to integrate, like, where would these interventions touch in that larger causal loop diagram. Then we bring it back and we get feedback about that, as well as particularly feedback on how, how and where the interventions are there, and discuss next steps with the team. So we only do that 6 times, it's nothing. You can imagine it's gonna be a lot of information, but it really excites me because I think it's, us researchers and experts, content area experts, can only get so far, really, especially when we think about like what is most important and what are systems and mechanisms that maybe we are not less, that we're less familiar with. This is just these are not my slides. Some of you may have seen them before. This is just, if you don't know what a connection circle is, what we're doing in session 2. You basically have a circle, you identify key variables, you start to connect them together, right? Like, how many French fries you eat impacts how much fat is consumed, which can impact concern about health risks. And then you have to sort of go through and make sure the loop is closed between arrows. So if you're interested, this website down here is really helpful and has a lot of information about what that looks like. The biggest anticipated challenges here, as I said, I'm so excited about these collaborative models versus the ones that we created from that prior project. But there are some definite anticipated challenges that I'm thinking about. One is keeping the model, the art form, as I was just talking about, between like overly simple versus, I have never shown a model to a group and had someone say, oh, this is too complicated, it could really be simpler, right? Everyone always wants to add. Well, what about these 5 variables? What about this? So we are trying to rank and prioritize throughout so that sort of the larger collaborative model building team understands the choices we've made. But I think there's going to be continual pushback to sort of keep it simple yet relevant. And then, of course, there are differences across groups and differences across campuses. And sometimes that's a bug in your model, and sometimes it's a feature of your model, really sort of understanding the mechanism with more nuance. And then I can also see a world where the model that we have, like the intervention that the team sort of prioritizes as potentially the most important, the loop to make that intervention work or be included in the model isn't there. So hopefully, because it's so iterative and we have this core modeling team to sort of give the feedback and continue the conversation, we can avoid some of those potential problems. But once again, this is still TBD. So I sort of apologize, I don't have the full results here, but I'm really happy to talk about this and also get feedback now before we've actually, implemented it. In the future, right, as I said, the aims 2 and 3, I think it's going to be actually really interesting to take that causal loop diagram and move it into FRED. In some ways, we know how to do this. This is what we've done in our other FRED projects. At the same time, I think in sort of the group model building literature and experts in these fields, there are a lot of conversations now about really how to do that best, right? Like, then you can go to literature. How do you parameterize? How do you know what you know and you don't know in terms of the model? So I actually think there are a lot of like interesting methodologic conversations we'll be able to have about moving our collaborative model into FRED. And then this decision support tool, which is something totally outside anything I've ever tried to do, but feels really important for like, why are we bothering to build these models if we're not going to actually do anything with it? And I think because, as I said, campuses, it's, 2 R01 side by side, and there's this randomized controlled trial, and we have decision makers from 30 to 40 campuses now already involved in RAISE, which is the RCT. So they're listening to us. So if we have a decision support tool, right, like this is the kind of instance where we can actually go to the people making decisions and hopefully present them with a tool that would be useful. And we have that relationship with them already to hopefully make that, a possible / inevitable conversation for us to be able to have with them. And so with that, I think that's been about 45 minutes. So I will stop. I do want to, as I said at the very beginning, I was so excited to learn about your center, and I would like to make a plug for the center that I direct here at Pitt for the Center for Social Dynamics and Community Health. We are a different center, but I think we actually share a lot of interests. And I'm also the associate director for the Public Health Dynamics Lab, which is really decision science, computer engineering, agent-based models. So that's more of like the technical method side. So we have a lot of that expertise in the School of Public Health. We are always looking to sort of, meet others with similar research interests to ours. So with that, I will stop and thank you all so much.
Thank you, Dr. Mair, for your great presentation. That was really enlightening and just amazing. I do not have much of a background in system science or agent-based modeling, so this was really eye-opening for me personally. We have a few questions in the chat.
Do you want me to stop sharing my screen or should I leave it up?
If you feel like it would help with the answers, you can leave it up or else we can take it down.
Okay.
So Natasha had asked a question early in the presentation. I think you kind of addressed this, but Natasha was interested in how you test your system science models with local stakeholders and how to support local agencies and even interventions. So I think you presented that you had this upcoming project, which you're excited about, but I think I was wondering too, like, have you had previous experience with this, or what are you most excited about in this upcoming project where you're working with the stakeholders?
Yeah, so a couple things. So one is that these models, like models within FRED, have already been used and are being used for sort of like, for example, we have a big project focused on opioid use disorder that's funded by the CDC in partnership with the CDC. So that's a collaborator who's not like a true community collaborator as I would typically think of them, but we're doing exactly that, building these agent-based models within FRED. We have monthly meetings with our collaborators at the CDC who say, what about this variable? What about this variable? We need to model this. We want to predict that. So at that like science, technical, national policy level, we've had some success doing this. Other people who have done group model building have had success, right? Like getting community input and then changing interventions. But I think it's a pretty it's a new-ish approach, and there are not a lot of people who've done it successfully so far. Why I'm so excited about this campus project is because we have these very strong relationships with our community collaborators already, and they have expressed a lot of interest in this project. So I'm hopeful this will be a really good test case for me personally to see how that works.
Great. And the project moving forward, is it still focused exclusively on sexual and gender minority students, or is it more opening up to?
This one is more open, campus? Yeah. So this is meant, so so RAISE is the acronym for the larger project, and it's meant to. We have a supplement attached to it that's really focused on trans college students. So like we have a real focus on trying to include in the work we're doing, include in interventions, those with minoritized sexual and gender identities, but it's not exclusively on that. It's meant to be sort of more broad in general on these campuses with, while still paying close attention to that group or those groups.
Okay. And so it looks like there's a few questions about the data and how kind of the data feeds into these models. So Kayla Delahaye asks, about the party model overview from kind of the beginning of the talk, the initial causal loop diagram. So how was that defined? Was it based on existing literature, data-driven, based on data you were using for the simulation model, or other methods?
Yeah, so it was a combination, as many agent-based models are. What we had were some really rich data sources, some from the specific, because it was a center grant, a P60. So there were like, new data collection processes ongoing. So there have been 10 years of data focused on adolescents in these same California communities. So we had distributions of drinking patterns by age, locations where they were drinking, how often they were drinking in these locations. So some of it was like we had data to be able to look to build that had not been analyzed. And then with agent-based models, typically, oftentimes, if there's a variable that maybe like there's a relationship that's in the literature that others have explored in other data sets that you can look at, and then using these like large already existing secondary data sets. So it's sort of like the data are a combination of your own data that are specific to the project, large open source or just, available to anyone data sources, as well as published literature that has, odds ratios or numbers. And then in terms of like, what are the loops, what's most important? It was a group of us who were really content experts. So myself and a couple folks were more like, I was the one sort of in the middle, and there were a couple of modelers who knew nothing about alcohol research. And then a couple people who were have been doing alcohol research amongst adolescents for 40 years, but had never heard of an agent-based model before. So it was a conversation between us, but that's also why I thought, oh, it'd be great. I'd love to hear what an adolescent thinks about this model, right? And that was missing from those initial models. And so, pluses and minuses.
Yeah, I really like the kind of community-based, work that you're doing with, those who are affected within the environment and within the community. I think that's very novel and so interesting. I'm gonna go to the last question, actually, because I feel like there were two questions that were kind of related to data, which I think you addressed. Okay. But the last question kind of gets at, loving from Jackson, loving the collaborative approach to abuse user values. Do you think about ways to design or compute optimal, quote unquote, intervention policies given some objective like reducing drinking, e.g. via Markov decision processes or reinforcement learning techniques?
Yes, that's an excellent question. So yeah, the short answer is yes. The slightly longer answer is that the thing about Fred and using, building these models with sort of a realistic synthetic population is we will be able to look at, say, Pitt, as well as Pitt Johnstown, which is a very different college, it's a very different context and a different student body and, different access to alcohol, et cetera. So the idea is really not just we're not assessing the entire model overall to say these 5 interventions together are the best. But we're really specifically trying to look what would be the best combination on Pitt's campus versus that campus. So what we're hoping to do with this one in particular is, if we have between 1 in 10 intervention levers built into the agent-based model, and this is what the AIM 3 is really meant to do, we want to find out from the perspective of the policymakers, do you want us to compare and contrast every single possible combination of potential interventions and see which looks the best, right? Using some of the methods that were mentioned in the question, et cetera, right? There are many ways we can do that. Or are you really only interested, you're only going to implement 2 policies, or you want to compare and contrast each one by itself, but you can look at combinations of them individually, and it will look different for each campus. So that's really the goal of this, is to do exactly that. Yeah, and there are, the methods for doing that are probably excessively technical to talk about here, but suffice to say, in a general sense, yes, and that's exactly where we're going.
Thanks. And I thought you just did a great job of kind of presenting these figures and, the pluses and the minuses and the equals, there wasn't complicated parameter estimates or coefficients in there. So it's kind of getting the basic idea of what these models, what's going on visually. So I think that was helpful.
Yeah, it's really hard to go into the details about any one model and not just do that for an hour, right? So there's a lot there, and these are papers that have massive appendices to them, right, and supplements, and yeah. Yes, I see a hand.
Yeah, I'd love. Thank you so much for this great presentation. And I think one thing that I'm curious about is the reception in the academic community around this work when you're involving the community stakeholders, right? I think that we at CAIS do a lot of community engaged work, right? And so this is, I think you are speaking to a group of people that are likely going to be enthusiastic about this, but I'm curious what some of the other reactions have been and whether or not there's been some pushback around, well, do these people that are, not experts in public health, do they really know what the causal mechanisms really are? Sure, intuition's great, but people give their own anecdotal stories. I mean, I'm just curious, what has been the reception of folks to this work?
Excellent question. Very perceptive. I'm guessing you can kind of guess what some of that has been. I will say that this is like the second time, not this exact presentation, but I gave a similar, introduction at another university, which I will remain unnamed for this. And that was the first question was, well, why would you think that, a bunch of college students would know better than researchers? Like, this makes no sense. Like, why would you just not rely solely on the research literature? That was the first question I got. So, but, that being said, like, I'm sort of used to, I'm in the Department of Behavioral Community Health Sciences. We are sort of even at the university level, the torchbearers for collaborative community engaged work. And I think people are coming around to in other fields and disciplines a little bit more. To answer a question, when someone asks me a question like that, I'll say things like, well, what they're doing is help us understand like the mechanisms that we want to build. And then we can go to the literature and go to the data to parameterize it, right? And get a value for this relationship. Like, we're not just fully making it up because, a bunch of teenagers told us this and who cares what teenagers think, right? Which I don't agree with that sentiment. But even when that happens, I think that there are, responses that people can be open to, but you're exactly right. Like the marriage of, I think simulation science systems thinking on its own is still not fully integrated. Community engaged research is not fully, it's a little bit more, but not fully integrated. And then you bring the two together and like, certainly there are not a lot of people who are, have already thought about this and are like fully on board without a lot of convincing. So that's, that's the work that has to be done ahead, the work ahead of us. So.
Yeah. And as a follow-up question, have you found that your community collaborators have they ever created mechanisms or causal pathways that when you get down to it, you just say, wow, we just don't have any existing data to parameterize this. And so they've introduced something that could potentially be very interesting, but it's kind of become a black box in our system.
Absolutely. And even when it's not even with, even with researchers, sometimes like a mechanism will come up and we realize that there's no data to parameterize it, right? And so that's why you kind of have to, to live with some black boxes in every model. I just like to think of these as iterative with sort of real world data collection as well, right? This says, okay, our community collaborators are bringing up this mechanism and wow, we really haven't thought about that or don't fully understand it. Sort of matches this idea over here, but it's also distinct. Like, is there more in-depth qualitative and or quantitative work we need to do to open up that black box because they're highlighting it as really important and it seems like it could be relevant for intervention A, B, or C. So yes, it happens. Sometimes it's like just a language thing in that we're calling similar constructs or concepts different things where they kind of match, right? And there's like a little bit off, or it would involve a little bit of tweaking, and sometimes they're fully novel. So yeah, I don't know for this one, I haven't done this specific one yet. As I said, the first meeting will be in a month. So I'll be really curious. The pilot that we're doing is with the Learning Collaborative and not students. We won't be involving the students until the start of the fall semester. So I'll be really interested to hear sort of the interventionists who have been doing this work and thinking about this a lot for their jobs, if they have ideas that are not sort of in the typical research literature. And I see we're almost out of time. And I think any other questions, or did I, hopefully I didn't run over too long.
We're just about at time, so don't see any other questions. Thank you so much for your time, Dr. Mair. It was enlightening and great presentation. And thanks everyone for coming out and attending and viewing it. We appreciate it.
Thank you so much.
And,
yes, thank you for this opportunity. I really appreciate it. So
it's a wonderful talk. Thanks so much for coming.
Yep, of course. Take care.
Bye-bye.
Bye.